Great. Well, I'm here with Dr. Joseph McCarthy, one of the past presidents of the International Society of Craniofacial Surgery, but more important, one of the founding members. And this is part of our founding member video series. Dr. McCarthy, I think it is a perfect opportunity to have a chance to chat with you here at NYU during a distraction course where it all started back in the 1990s, where you really introduced distraction to craniofacial surgery for the first time. What have you seen in this course? Has distraction evolved? Was it how you anticipated the technique would change over 20, 30 years?
Well, here we are in May 2024. I think our research started in 1986.
Yep.
The first patient was 1989 in this institution of unilateral mandibular distraction. And the first course was in 1994.
Mm-hmm.
It's about 30 years to the month. How do I feel today? Well, let me tell you how I felt when I started. I mean, we had an idea, and I didn't know where it was going to go. And the NYU team, I just can't give them enough credit to for making all of this possible. Did I think almost 40 years ago that there'd be a meeting like this today? No. Mm-hmm. But I think it's all in the spirit of surgery, and the spirit of surgery has a lot of curiosity. I think in the operating room or the clinic, we should always be thinking, is there a better way? Are we committed for the rest of our professional life doing it this way? Are we satisfied with it? And I think the development of craniofacial distraction really represents an element of curiosity and also an element of asking questions of yourself.
And back in 1994, that first distraction course, there must have been a terrific amount of enthusiasm about this new technique and wondering where it's going to go. Do you sense that enthusiasm is still there today, at this 2024 course? Like, how do those two courses compare between 1994 and 2024?
Oh, I think in many ways very similar. Mm-hmm. Obviously, in 1994, there was a lot of excitement and curiosity and what's going on. Am I doing it? Am I doing it according to what is state of the art? And that same spirit is here today. Mm-hmm. And what is especially heartwarming for me is to see all of the young surgeons today. There's this continuity or flow, I think, in all human endeavors. And it's certainly apparent today.
No, absolutely. And back in 1994, maybe, or even when you did your first mandible distraction case, you had a hope for this technique. You saw the promise of this technique, and it's definitely shown its promise. What have you been most satisfied with the technique of distraction of the craniofacial skeleton? And what has maybe surprised you, or maybe something that you didn't see as, maybe being a problem with distraction that you didn't anticipate back in the 1990s?
Well, I think what satisfies me the most, and I think this represents what's going on in all fields of medicine today, is that distraction is less interventive. Mm-hmm. I had mentioned earlier the first craniofacial case that I was involved in was 1971, when I was a resident here, and Paul Tessier was the Cassangian professor. Mm-hmm. And I was a resident, and Sam Hammer and I assisted, were not assisted, we were the residents scrubbed, and Tessier did a subcranial Lefort 3 and a frontal orbital advancement. And he was assisted by my mentor, John Converse, and I mentioned yesterday the operation went 18 and a half hours, and I think 8 units of blood were replaced. So you say, what pleases me today is a procedure like this is done in several hours. 50% of the time, blood replacement is not required, less complications. That's what pleases me, is the surgical progress. And maybe someday we can look forward to where it's an injection of this and a slight 1-hour procedure, and this is the progress you want. And as I said, it really requires curiosity, asking questions of yourself. So I'm very optimistic.
Yeah. And anything surprised you about distraction? Something you didn't see as a limitation?
No, I'm impressed at compared to the way we did things in the 1990s. It's even less interventive,
Mhm.
fewer secondary procedures.
Mhm.
I mean, the ideal would be to operate on a child and do one procedure, and that was it forever. And now we still see that multiple operations are required for the same patient. And I think what I'm taking out of this meeting today is that we're developing protocols. We have more of a handle on knowing when to operate and when not to operate, and to limit the number of procedures children with craniofacial anomalies will have to undergo.
Yeah. And you have a rare perspective because you mentioned, you were a junior in your training when you saw Paul Tessier and others bringing these paradigm
Yeah.
shifts, into craniofacial surgery. You brought your own paradigm shift with distraction in the 90s. What do you now, if you turn the other direction, what do you see? Where's craniofacial surgery going as a surgery subspecialty? Not as a society, but as a technical set of skills.
Well, I keep on getting back to simplifying the techniques, making them less interventive. And I recall we used to use the term inductive surgery as the future. In other words, with a minimal procedure, using some sort of factor that would accelerate bony consolidation.
Yeah.
The ideal probably would be as if we could, in a surgical procedure, do a full distraction or lengthening of the bone, and then set up a situation where we could get rapid deposition of bone and consolidation of bone,
Mhm.
rather than a 3-month procedure post-operatively. Now, I think it will require good thinking, critical thinking, and I think it will also require looking at where we need to improve, where we stand now, and developing techniques that will make life better and the treatment process shorter for our patients.
Yeah.
But it will depend on research.
Yeah. Yeah. Which is harder to
Yeah.
achieve
And I
nowadays.
think
Yeah.
as surgeons, we have to get away from coming to meetings and say, this is how I do it.
Mm.
Here's my magic surgical recipe. And probably come to meetings and say, how can we do this better? What should we be doing better
Yeah.
or
Yeah.
differently?
Yeah.
Yeah.
Absolutely. The other perspective you have is as it relates to our society, our International Society of Craniofacial Surgery. So you were that founding member. It was just a gleam in all the founding members' eyes when they first met. It's evolved a lot over the years, with the successive meetings. How do you look back at that growth of the society as a whole? How it's
Oh, I
changed?
can say nothing but with fondness.
Hmm.
Even coming into the meeting here and seeing old friends, new friends, and through it all at the International Society meetings, there has always been goodwill, collaboration, development of friendships. I have nothing but great fondness for the society and the meetings we've held over the years.
And what's your perspective about where the society should be going? What can we do to continue that evolution?
Well, I think education is the key thing,
Mhm.
and meetings. And I personally am of a generation that I prefer in-person meetings.
Mhm.
Sitting in front of a screen is not my idea of a meeting, because I think as colleagues, we have to get to know each other and trust each other. And I think that is very hard to do virtually. I think the society should also move into developing protocols for different conditions. We would like to have not a rigid protocol, because I think those can be dangerous, but still when to operate, at what age, and try to provide guidance as to how the patient should be treated. So I think the development of protocols would be a very good thing for the society to do. I think the society should also promote the development of critical clinical research, where the different centers have to follow their patients long term and come to meetings and say, I've had 20 patients who've done this and that. And I think that would be another good thing that the society could promote. The other thing would be to promote basic science research on bony development, bony healing. And that's a big nut to crack because it's expensive and everything, but it still can be done in an academic center. And I think sponsoring institutions like the National Institutes of Health would be very receptive.
I'll make sure to bring those ideas to the council meeting, because you're right. I think that is the direction that the society is ready to go into, is education and research and protocol development.
And you look at the last, 40 years of the society.
Yeah.
We've benefited from a lot of research that has been done.
Yeah.
I mean, the first distraction case was done based on research, canine research. And I never went before the IRB, but I remember talking to the boy's mother and saying, I genuinely feel this is going to work because we've been able to demonstrate it in the laboratory.
Yeah.
And I think to have recommended an operation out of the blue without that laboratory research, I think would have raised serious ethical concerns.
Yeah, I think you're absolutely right. Well, Dr. McCarthy, on behalf of the ISCFS, I want to thank you for founding us and founding our society.
I was one of a group.
One of a group, but it takes many to make things like this happen.
At the meeting today, I got a boot out of the fact that one of the speakers, more of your generation, said it when he was a young craniofacial surgeon. It was ruled by a group of, what did he call them? Minor deities. Deities. Well, I hope I'm not looked at as a minor deity.
I think you're close to a deity, but not a minor one. And also just your innovations to craniofacial surgery will last forever. But personally, I just wanted to thank you for stimulating my interest in craniofacial surgery 23 years ago and forcing me and teaching me how to think outside the box. My career thanks you.
I think one of the joys of academic surgery are the young people you come in contact with and watch them evolve. That's a big treat.
Absolutely. It's been a pleasure. Thank you so much, Dr. McCarthy.
Thank you.